truly honored to be a part of this joint symposium between the AASLD and the Taiwan Association for the Study of the Liver. Today, I will be talking about trends of hepatitis C-related HCC risk after DAA treatment in the United States. Here you can see my disclosures. Hepatitis C affects over 71 million people worldwide, with the highest burden in Europe, the Middle East, Southeast Asia, and the Western Pacific regions. Of those who acquire hepatitis C infection, most will develop chronic infection, and approximately 20% of those will develop cirrhosis over the next 10 to 20 years. As we'll discuss in more detail on the next slide, the risk of HCC is substantial at 1 to 4% per year once cirrhosis develops. Here we can see historical data from the HALT-C trial to see the risk of HCC in patients with untreated hepatitis C infection. As you may recall, HALT-C was a multi-center trial in the United States which preceded DAA therapy and randomized over 1,000 patients to maintenance interferon or placebo. These data are after a median follow-up of 4.6 years, during which time 48 HCCs developed. The annual HCC incidence in this study among those with cirrhosis was 1.4% in those with cirrhosis, but lower at 0.8% in those with advanced fibrosis but no cirrhosis. The cumulative 3- and 5-year incidence rates of HCC in those with cirrhosis were 2.6% and 7.0% respectively. Now, despite a focus recently on advances in HCC treatment, prevention continues to remain the most efficient and cost-effective way to reduce HCC-related mortality. The most effective means for HCC prevention have been hepatitis B vaccination and hepatitis C treatment, with the latter being the focus of this talk. Here you can see the typical framework of prevention, including primary prevention, that is removing a risk factor to reduce cancer development, secondary prevention, which includes efforts focused on early detection or reducing cancer progression, and tertiary prevention, which focuses on reducing complications of established cancer, including reducing recurrence after curative treatment. For purposes of this talk, I will really be focusing on primary and tertiary prevention using DAA therapy and how this has impacted hepatitis C-related HCC epidemiology. Now, as we think through these different levels, the population impact of each type of prevention is largely driven by the relevant denominator. Primary prevention affects the greatest number of persons since it's looking at the at-risk population, such as those with viral hepatitis or other forms of chronic liver disease, including cirrhosis. Secondary prevention would largely focus on those with the greatest risk of HCC, such as those with cirrhosis or subsets with chronic hepatitis B. And finally, tertiary prevention would only impact those with established cancer, which is once again a fraction of those with the at-risk phenotype. Despite this, each is important when thinking through a comprehensive prevention program. So we'll start our discussion with primary prevention. Of course, the epitome of success for primary prevention of HCC has been implementation of hepatitis B vaccination programs, such as the national program here in Taiwan, which has resulted in significant declines in HCC incidence. While we have seen remarkable advances in hepatitis C treatment, the search for a vaccine unfortunately remains elusive. Therefore, primary prevention of hepatitis C-related HCC has primarily been focused on antiviral treatment. When we think of other risk factors that can be potentially addressed, we used to list several of them, with many of these listed on this slide. You can see that there are some modifiable risk factors, including presence of metabolic syndrome, and then there are non-modifiable factors such as age and sex. However, by far the most important modifiable risk factor these days is the presence of active viremia versus sustained virological response after antiviral treatment. Historically, it was well recognized that interferon-based hepatitis C treatment was associated with significant reductions in HCC risk, both in clinical trials as well as subsequent cohort studies. As expected, antiviral therapy was more helpful in responders than non-responders, since most of this effect would be driven by sustained virological response and improvements in liver inflammation and liver dysfunction. However, it was unclear if this was the predominant mechanism or if some of this reduction was also a direct interferon effect, such as inducing pro-apoptotic genes, inhibiting angiogenesis, or augmenting anti-tumor responses. And this question became particularly relevant as we shifted from interferon-based therapy to DAA-based therapy. Now, fortunately, there are now data showing that DAA therapy similarly reduces risk of HCC, with one large study shown here from the Veterans Affairs Health System in the US. The annual incidence of HCC was 0.9 per 100 person years, compared to 3.45 in patients in those without SVR. Significant difference in terms of HCC risk. And this difference remains significant with a 72% reduction even in adjusted analyses. One thing worth noting is that patients with cirrhosis have persistent risk of HCC even after SVR. This risk, while abated, continues to be above cost-effective thresholds for HCC surveillance for several years post-SVR. And there is currently no time cutoff after which HCC risk is sufficiently low to stop HCC surveillance. In contrast, the risk of HCC in those without cirrhosis remains low, with annual incidence rates consistently less than 1% across nearly all subgroups. Now, the one subgroup that was an outlier was those with an elevated FIB4, highlighting, of course, it's important to carefully consider fibrosis severity at the time of SVR and make a careful determination about the need for continued surveillance. A recent decision analysis from Jordan Feld and colleagues also addressed the benefit of HCC surveillance in patients with hepatitis C cirrhosis versus advanced fibrosis after SVR. Now, the authors first confirmed that surveillance was cost-effective in patients with cirrhosis, with an incremental cost-effectiveness ratio below 50,000 per quality-adjusted life year, as highlighted in the green boxes. However, surveillance was not cost-effective in patients with F3 fibrosis, with incremental cost-effectiveness ratios exceeding $100,000 per quality-adjusted life year and approaching $200,000 per quality-adjusted life year if performed semi-annually, well above accepted cost-effectiveness thresholds in the United States. Once again, while there's a risk of misclassification that should be considered when thinking of a patient as on a case-by-case basis, this study highlights that surveillance likely should not be done on a population basis in patients with advanced fibrosis but no cirrhosis. Now, in light of these data, it's not surprising that we're starting to see a shift in cirrhosis etiologies away from viral hepatitis and toward a disease that's being driven from alcohol-related liver disease, NASH-related cirrhosis, as well as cured hepatitis C. And this was really reflected in a recent publication describing a contemporary cohort of cirrhosis patients undergoing HCC surveillance from a multi-center cohort in the United States. As you can see here, the proportion of patients with active hepatitis C on the left-hand side of the slide was below 25% in all three racial ethnic groups. In contrast, 25 to 50% of patients had treated hepatitis C, 25% had alcohol-related liver disease, and 25% had NASH-related cirrhosis. In parallel, we're starting to see a decline in hepatitis C-related HCC incidence and mortality. This study from the National Veterans Affairs evaluated the incidence of hepatitis C-related HCC among veterans from 2002 to 2018 and looked at those with viremic versus cured hepatitis C infection. Focusing on those with hepatitis C infection, particularly after introduction of DAAs in 2013, as highlighted by the red box, we can see that the incidence of hepatitis C-related HCC was initially increasing each year through 2015, but then declined thereafter. After 2013, we see a plateau of HCC patients with active viremia, followed by a decline shortly thereafter. In contrast, the incidence of HCC in those with cured hepatitis C steadily increased after 2013. Once again, despite these differing trends, the overall incidence of hepatitis C-related HCC declined in the most recent years. This recent brief report in gastroenterology examined trends in HCC and cirrhosis-related mortality in the U.S. using de-identified multiple cause of death files from the National Vital Statistics System. The authors found that age-standardized HCC-related mortality trends differed by etiology. As you can see, for hepatitis C-related HCC, they noted that mortality significantly increased between 2009 and 2014 from 0.96 to 1.21 per 100,000 person years, which represented a 5.4% annual increase over that time period. However, after 2014, that is shortly after release of DAAs, we see a decline in hepatitis C-related HCC mortality from 1.21 to 1.04 by the year 2018, with this latter period representing a 3.5% annual decline in mortality, statistically significant decline. In contrast, over this time period, mortality from alcohol-related HCC and NASH-related HCC increased steadily over the entire study period. Despite these data showing reductions in HCC risk after a DAA treatment, paired with minimal restrictions and favorable adverse event profile, many patients globally remain undiagnosed or untreated. Data from the WHO as of 2018 show we continue to fall far below our targets for 90% of patients being diagnosed and 80% being treated. As shown in the color scheme, this truly is a universal problem in every region of the world, highlighting a need for programs to better identify patients with hepatitis C, link them to care so they can get treated and we can reduce HCC incidence and mortality further. Now, for the remaining time, I want to address tertiary prevention, that is the impact of DAAs on risk of recurrence after curative treatment. As many of you know, an area that has been controversial over the last few years. Patients who are detected at an early stage are amenable to curative therapies, including surgical resection and local ablative therapies. Both are associated with potential for long-term survival, but limited by high risk of recurrence, approaching 70% by 5 years after the procedures. This includes a combination of early recurrence, often micrometastases from the initial tumor, and late recurrence, often related to a field effect with the underlying liver disease and a high risk of de novo tumors. Now, similar to HCC occurrence in patients with cirrhosis, interferon-based therapy was shown to reduce HCC recurrence in patients with a history of HCC after curative therapy. Here I show data from a meta-analysis showing that interferon therapy significantly reduced the risk of HCC recurrence at 3 years, although you can see that effect size is much smaller than what we're used to seeing in terms of recurrence, with only a 17% reduction seen at this 3-year recurrence rate. Now, with the shift from interferon-based therapy to DAA therapy, there was hope that greater patient eligibility would translate into reduced recurrence on a greater level. However, all of us remember that early data from a multi-center study in Spain showed a higher than expected risk of early recurrence, with over 25% of patients having recurrence within 6 months. The supposed mechanism of action here was thought to be a decreased immune surveillance of microscopic tumor clones in the setting of decreased hepatic inflammation, which could then lead to increased and more aggressive recurrence. Now, there have been several studies that have evaluated this subsequently, and I'm showing you here one that we conducted in the United States that has refuted this initial publication coming out of the Spanish group. Now, in a subsequent multi-center study among nearly 800 patients with HCC who achieved cure from surgical or local regional therapy, we compared DAA-treated and untreated patients in the U.S. and found DAA therapy was not associated with increased risk of recurrence in adjusted analyses. As you can see here, hazard ratio of 0.90 and the 95% confidence interval extending to 1.16. It also was not associated with early HCC recurrence with a hazard ratio of 0.96, once again crossing 1 at the upper limit of the 95% confidence interval. We performed landmark analyses to account for risk of immortal time bias, and we found that the results were consistent in these landmark analyses, as you can see here. In this study, we also examined tumor stage and response to treatment, and we found no difference in tumor aggressiveness between DAA-treated and untreated patients. Now, of course, this was a cohort study, and we acknowledge that there was a risk of residual confounding, risk of ascertainment bias given the non-randomized nature of the study. However, this continues to remain one of the largest studies, that particularly with a comparator group, and we believe that these are likely the best data available and should allay the fears of increased recurrence risk at this time. Now, subsequently, we examined overall survival in these two groups in a follow-up publication. And this was important in light of data from the Italian groups showing that liver decompensation remains one of the leading causes of death in patients who undergo curative therapy for HCC. And we found that DAA therapy was in fact associated with a 46% reduction in risk of mortality, with a hazard ratio of 0.54. And this association was observed in patients with SVR, with a hazard ratio of 0.29, and not in those without SVR, as one would expect, given any improvement in survival would be mediated through achieving sustained virological response. And so this subgroup analysis, I think, really argues that this is really a true phenomenon and not simply related to confounding. Results were otherwise consistent across most subgroup analyses that were conducted as part of the study. Now, earlier this year, another study, including patients from 2 U.S. centers and 6 Asian centers, reinforced that SVR is associated with reduced mortality among HCC patients, and they found a hazard ratio of 0.37, so 63% reduction in mortality. Most of the patients in this study were also early stage HCC, once again reinforcing findings from the prior study that I showed you. However, increased data in patients with intermediate and advanced stage disease are likely still needed. And this is particularly of interest in light of improvements in the therapeutic options that we have for these patients, with these patients now achieving median survival somewhere between 2 to 3 years, much better than the 1 to 2 years that we used to see just even a couple years ago. We recently finished collecting data to address this very question and hope to have data available in early 2021. Now, when we think of this latter question, one thing that we really need to consider is the lower efficacy of DAAs to achieve SVR in patients with active HCC. On the left-hand side of the slide, you can see data from a study among over 17,000 veterans undergoing DAA treatment, which found that SVR rates were 74% in HCC patients versus over 90% in non-HCC patients, with a consistent effect across all examined genotypes. These data were recently reinforced by a systematic review which showed that SVR was preserved in patients with a history of HCC, although significantly lower in those with active HCC, with SVRs in the low 90s in those who have a history of cured HCC compared to low 70s in those with active HCC. However, these patients are at notable risk of hepatic decompensation, so there still may be benefit despite this lower SVR rates, therefore highlighting the need for data in this patient group. In summary, chronic hepatitis C has been one of the most common causes of HCC worldwide. Primary prevention is important for us to reduce HCC incidence and mortality. However, we still need continued efforts to find a vaccine. Therefore, currently, primary prevention is largely focused on hepatitis C treatment. Clearly, hepatitis C screening and DAA therapy are essential and have started to reduce HCC incidence and mortality. However, we continue to fall below WHO goals, and we need to do better in terms of programs for HCC screening and treatment. In patients with a history of HCC, we've shown that DAA therapy is safe, is not associated with an increased risk of recurrence, and likely reduces mortality in these patients. We have data showing benefit in early HCC, but clearly we need data evaluating the benefit of DAAs in those with active HCC so we can once again continue to reduce mortality as much as possible in this patient subgroup as well. Thank you. I'm happy to take questions at the end of this session.